with the impulsivity session. I've also been informed there's a breakout room that's being live streamed. You do all have seats now, but it is still cozy, so if anyone would want to join the breakout room, you're very welcome to. Continuing in the impulsivity theme, it's my great pleasure to introduce Professor James Rowe, who's Director of the Cambridge Centre for Frontotemporal Dementia and Related Disorders. James is, of course, an accomplished scientist as well as a neurologist, and I'm looking forward to his talk today. James, over to you.
Thank you very much. It's fantastic to be back at the BNPA with so many old, or at least long-standing friends. And we're going to hear about apathy and impulsivity. Hugh and Stefan have sown the seed a little bit, so we're going to hear a bit more about this and some new approaches that are leading the way to alternative treatments. No declarations that are relevant to today's material. But just to set out the program, we're going to talk largely about apathy in the first instance, then link across to impulsivity and show why they come together so often. We'll hear a bit about the neuropsychological aspects of the disease, how it relates to brain function, why it's so functionally impairing, and indeed why it's so bad for your long-term survival. Okay, so this is the outline, and how that then may lead on to new ways to think about treatment. We do not have good treatments for apathy, some modest treatments for impulsivity, particularly young psychiatric populations, but not really in people with older neurodegenerative disorders, but that will change, and as we'll hear about, that's the next 20 minutes. I just want to spend a moment reflecting what apathy is, what it means to different people. And if you were to ask your neighbour or ask people on the street what they think apathy is about, you're likely to get a lot of very negative terms. Okay, I think the top list there on the right-hand side are much more sort of lay ideas, what it must be like, or what they think's going on. Some more sort of technical terms on anhedonia and inferences about anticipating pleasure and so on. But they're all very, very negative and loaded. And we need to remember there's perhaps another aspect, a patient perspective, who is when you're apathetic, which is much more positive. We can talk about it in terms of contentment. You're happy with the way things are. I'm not doing stuff because I don't really want to. It's all right. It's very difficult for other people around you, and it's not good for your survival. But in the moment, it's not too bad. You have equanimity. You're calm. You're relaxed. Yeah, too relaxed. But, you know, that's all right. And we should forget, actually, historically, terms like ataraxia, so ancient gentleman philosopher Greeks would absolutely sort of cultivate a state of detachment rising above the vicissitudes of the modern world, highly sought after, and not a million miles from nirvana, the state where there's no suffering because you negate desires, you stop the strife. It's not happiness nirvana, it's about lack of strife and suffering through lack of goals. So historically there are some different aspects on apathy. We need to remember that when we think who are we treating and what risks will make them take. But if we leave sort of philosophical speculations aside and come back to the neuroscience, we have to start by saying apathy is a quantitative reduction. It's a measurable, observable reduction in goal-directed behaviors. You're not undertaking goal-directed behaviors. And if you follow that line, you have to realize it's a behavioral construct. It's not an emotional, psychological state necessarily. You might infer such a thing, but primarily it's a construct. And it's not about not moving. People may not move when they're apathetic, but it's not the movement that's the problem. It's not akinesia. Young adults with depression may develop apathy, but most apathy is not underdiagnosed, misdiagnosed depression. In fact, most of the patients I see with apathy are not depressed. If you ask about them, they're fine. Right? They don't do anything, but they're not depressed. Okay. So you have to distinguish depression carefully in studies. That's doable. You may see that they don't initiate things. You'll hear terms like cognitive apathy, and I would push back on that. Because actually, if we drill into what people mean, it's really just another word for executive functions around attentional control, task switching, and so on. And we'll touch on why that's relevant later, but it's not really apathy directly. The literature on apathy is dominated by motivational deficits, okay, aspects of reward. But I'm going to show you a video in a moment of a chap who's very apathetic from frontotemporal dementia. And I want you to note that he's not akinetic. He does move. He also is not bradiphrenic. He gives some answers to my questions with quite a short latency. And he's not amnestic. We eventually get to the right answer, but it's like pulling teeth. I'm just going to spend probably about a minute of this precious 20 minutes, but it's worth just watching what apathy is like. It's not a very exciting video, but it's worth watching. Right? It's really hard to make an exciting video. So let's play the video if you can. Thanks. Can you tell me, who's this sitting with us today? Have you met her before? Who is she? Can you remember what she's called? Is she a friend or someone in the family or someone who works here? Does she work here? Is she a member of, is she in the family? Yeah.
Is she your daughter? This lady?
No.
No, she's not your daughter. Who is she?
She's my wife.
Oh, thank God. And it's like pulling teeth.
Absolutely, she
Yeah.
is.
He knows the answer and he gets there. Thanks so much.
And her name?
So we know he knows the answer and he's engaged in the conversation, but trying to get him to engage constructively with meaningful answers. And he sits on all day on the sofa. At home, very difficult to live with. She's got behavioural variant frontotemporal dementia. Yeah. He hasn't got those extrovert, sort of in-your-face, confrontational behaviours, but he's got profound apathy. And you can see from he's put on a bit of weight with the sweet tooth. It's a behavioural variant FTD. I'm going to talk a couple minutes on the classical model, the classical hypothesis of apathy, is that actions are undesirable because either you don't really represent how much reward you'll get, or you think there's too much effort. So there's effort avoidance or reward insensitivity. And there's this balance under the classical model between the cost and benefit, effort and reward. And if the perceived benefit is not enough, or the cost and effort is seen as too high, you'll be tipped away from undertaking any action. Okay? So cost and benefit. In research, you tend to talk about efforts and rewards, okay? But it's basically cost and benefit. But of course, if that balance is moved in the other direction, that you overvalue or over-expect rewards, and you underplay or don't recognize risks and costs, you'll be tipped towards impulsive actions under the classical hypothesis of apathy and impulsivity. And it introduces this antagonism between apathy and impulsivity. So I just want to actually touch on what impulsivity is all about. And it's a complex set of behaviors, and Hugh spoke about the complexity and diversity, but there are some common features. And really, impulsivity encompasses taking behaviors that fail to take due account of risks and rewards. You may ignore the outcomes. Okay? I've had patients doing this very thing, okay, with hedge trimmers. It may be you act too quickly, fail to take on board enough information before you make a decision. You may be just intolerant of delay, impatient. Or you may be unable to inhibit actions. You cannot stop yourself when you should. So all these are different aspects of impulsivity, and they're all highly represented in those common neurological, degenerative, developmental disorders that everyone in this room is here because they see, just some of them listed there, but and more. They all feature impulsivity. The classical model of apathy and impulsivity sets up this antagonism between the two, that apathy is somehow about being slow, not doing enough, low reward, high effort, really driven by a lack of dopamine or dopamine sensitivity under the classical model. And the impulsivity is doing too much too quickly, overestimating rewards, underestimating risk, and it's being hyper-dopaminergic. Okay? So you get this dichotomy between hypo and hyper-dopaminergic state under the classical model, and it's profoundly wrong. Okay? This is wrong, wrong, wrong. Two reasons. I can tell you it's wrong. There's lots of reasons it's wrong, but two to hold on to. One is, under natural states of apathy, dopaminergic drugs do not treat the apathy. Artificial models, like a dopamine depletion model, you can restore the apathy by giving dopamine, but that's such an artificial setup. Natural apathy in the syndromes we see are not helped with dopaminergic drugs. Okay? Also, the biggest killer for this classical hypothesis is that apathy and impulsivity are not antagonistic. They're not a Jekyll and Hyde, okay? Which is kind of how the classical literature would have us believe. That is not true. They're positively correlated. Okay? People who are apathetic are also impulsive and vice versa. And we see this in Parkinson's disease, frontotemporal dementia, PSP, healthy populations if you do large-scale studies. And some of them listed at the bottom there. This is a local study looking at people with frontotemporal dementia and PSP. More apathetic on the y-axis, more impulsive on the x-axis. It doesn't really matter how you've measured apathy and impulsivity. There's just two common tests I'm sure you'll have heard of. So let's look at another situation, PSP. Okay, a motor disorder, motor cognitive disorder. We look back over the last 140 or so patients, and we looked at the concurrence or separation of impulsivity to a clinically significant degree, as was discussed in their notes. Clinically significant apathy, clinically significant impulsivity, and also emotional ability. And 2/3 of patients were both apathetic and impulsive. Okay? It's normal to be both. In fact, it's the norm in PSP to be both apathetic and impulsive. So what does this mean? How do we think of such a patient? Well, they're sitting on the sofa all day, very apathetic, but the few actions they do, the few things they do when they first get up from the sofa might be to give money to strangers at the door or to bet it foolishly online. They might seek pornography or otherwise inappropriate material online, and they might do physical things that put them at high risk of accidents. Okay? So you can be apathetic and impulsive quite happily at the same time. Okay? So picture that patient sitting on the sofa, but the few things they do when they get up are high cost, have bad outcomes, poor choices. Okay? So let's come on to some data. We need to think enough speculation. Let's come on to some evidence. For this, we need to understand quantitative what apathy and impulsivity is all about in epidemiological populations, in other words, representative populations, not just those that come back and back into studies and a very sort of slightly biased group of people. So we set up about 12 years ago the Pippin study in East Anglia, trying to identify every patient with a disorder associated with frontotemporal lobar degeneration. In other words, behavioural event, frontotemporal dementia, primary progressive aphasias, progressive supranuclear palsy, and corticobasal syndrome. They form a cluster of diseases with commonalities in pathology. And with this phenomenal team, over 3 successive phases of the study, Ian, Alex, and Catherine identified 520 patients, and we've managed to see in person around 80% to verify the diagnosis, and the majority of those we managed to get a reasonably decent and complete neuropsychological battery, which I'll show in a moment. So a lot of patients epidemiologically represented. We're trying to kind of find every patient we could in this geographical area. And for those that did neuropsychology, we measured apathy and impulsivity with a variety of classic tools, questionnaires and rating scales, some by carers, some by the patient. You'll recognise some of them here. Lots of different questionnaires and scales. We also measured disease severity in cognitive screening and other severity scales. And we also undertook some laboratory-based studies about inhibition, like the studies Hugh was talking about, stop, no-go inhibition, gambling tasks and the like, trying to probe risk-taking and inhibitory control. So all those tests, quite a lot of data per patient, lots of variables. To understand how they relate to each other, those core components, we took all those variables and we took them forward into what's known as principal components analysis to understand the statistical dependencies, the relationships between them. So put them all into principal components analysis, and that gives you a low-dimensional extract, the modes or components of behavioural change. Where things are highly correlated, it brings them together. Where things are unrelated, it separates them apart. Okay? Makes it very efficient. So, first component, apathy and impulsivity, sat together, as we'd expect, highly correlated. They actually become part of one component. We call it challenging behaviours, this combination of apathy and impulsivity. And across the disorders, apathy and impulsivity, this joint component, was very common. It's highest in red in behavioural event frontotemporal dementia. I mean, that has to be because it's a defining feature under the criteria. Okay? But notice in PSP in blue, corticobasal in green, even semantic dementia in orange, there are many patients who are expressing apathy and impulsivity to the same degree as the people whose illness is defined by it, behavioural event frontotemporal dementia. Okay? Maybe these symptoms weren't there in the beginning when the diagnosis was set, but cross-sectionally during the disease evolution, they're very common. And it's very, very bad for you. So in the first study, we just looked at survival. So even if you correct for the disease group, one standard deviation increase in how much apathy and impulsivity you have represents an 80% increase in death 2.5 years later. It's a massive increase in death. Okay? 80% at 2.5 years. Okay? Much more than your age. It's a much bigger effect than how old you are. And it was more important than cognition and other things. So it has really important but bad news for your survival. If we just look at independence, we followed this up looking at nursing home or death. Okay? In other words, what's your chance of being not in a nursing home and still alive? It's called independent survival. And Alex Murley undertook this work. If you've got either high versus low expression of this apathy impulsivity construct, okay, your median survival is about 18 months to 2 years different. About a third of your disease survival. These are quite rapid diseases. Okay, so from the time we see you, it adds about a plus minus a third in terms of survival. So it's hugely important. Apathy and impulsivity, they come together and they worsen prognosis. So let's just think about next 5 to 10 minutes why they come together. How is it that these intuitively so distinctive behaviours actually sit together? What they both represent are jointly a failure to take contextually appropriate action. Okay? You're not doing something when you should, and you're not holding back from something when you shouldn't. Okay? So it's around a faulty decision, quality decision. And the way we look at this is that actually the behaviour that you choose to do, that decision about behaviour, needs you to anticipate and understand the outcome of your actions. Okay? So we're promoting actually a very radical rethink of the way we should, from a neuroscientific perspective, approach apathy. That we call it failure of active influence, but essentially it's not that actions are undesirable, like the old model. Actions are fundamentally just not necessary. Okay? They become unnecessary, because even if you know the reward and it's something you like, you can tell me, I like doing this, you know, the patient might say. And even if the effort is manageable, often it's very trivial things people don't do. The expected outcome of their actions, their own understanding of the consequences of action are very imprecise and vague. And to illustrate why that's a problem, I want to imagine you're sitting at home and it's light, and as evening comes on, it gets a bit darker, and it gets a bit darker still. At some point, you'll get up and turn the light on, probably. Okay? Yeah? But how dark does it have to be before eventually you turn the lights on? Yeah? Will vary. If you're very apathetic, you'll just sit there as it gets darker and darker. You might like the light, you might not like the dark. That's not enough to make you get up and turn the light on. Okay? So why not? Well, why do you turn the lights on? You have to know that it's getting dark. You need some sort of light detector. Well, there's no problem with vision as such. Okay? The light meter's working. You need to have some sense that you prefer the light to the dark. You need to care about it, if you like. And there is a reward aspect to apathy and impulsivity, don't get me wrong. But that's only one part. What you also need to do is to believe that if you get up and turn the lights on, it will have any consequence for the lightness of darkness. We all believe the light switches work, usually. Okay? So it's very predictable, and we can be confident if I got up and flicked the light switch, the lights will come on. That's great. If you didn't believe that, you'd be disinclined to turn the lights on, even if it's dark. You might not like the dark, but your sort of sense, I'm going to go and turn the light on if I don't believe it's going to work, well, it wouldn't be there. So you have to believe, with some precision, some confidence, if you like, that action will make a difference. So you can only take these actions, you will only take action, I've got a goal-directed behaviour, if you believe, and I'll call it sufficiently strongly, in the outcome of your action. And I'm going to give another daily example to help with this intuition, because it's a strange concept. Imagine you're an archer, okay? And you take a shot. And if you are confident that knowing, how did it go? How did it feel? Did the pull went well? And what are the conditions? I'm pretty confident I'm going to hit the bullseye, okay? You have a strong expectation called a prior. It's a prior expectation, a belief in how good your shot will be. You think, I know where that's going to land. And the arrow comes in and it lands off target. Well, if you were very confident, precise in your prior expectation of the consequence of your actions, you say, damn, I missed. I can see there's a difference. I'm going to have to take action to adjust and be better next time. I might change my stance or improve the bow. I'll do something in a goal-directed way to improve the outcome. But imagine you're actually a bit fuzzy. You kind of, well, I'll shoot the arrow and it'll hit somewhere. I'm very uncertain. I don't really know where it's going to land. It could be anywhere. But actually, no matter where the arrow hits, it's close enough. Where the arrow lands is encompassed within the spectrum of possibilities that you already thought might happen from my action. Okay? So it's close enough. And if it's close enough, you don't need to take any action on the next shot to improve. You're good enough. Okay? So the precision in which you held the outcome of your action is going to determine whether you need to take any action subsequently. So now it comes this critical aspect of precision. So apathy emerges when actions are unnecessary. So formally, in the scientific term, we talk about weak priors on the action outcomes, but in lay terms, it's basically you live in a world which is close enough, is good enough. Okay? The world as I see it is close enough to the world as I want it. So I don't need to close the gap. I don't need to do anything to close that gap. Not that I don't notice the difference, not that I don't like the world as it might be. I might like to hit the bullseye or have the lights on, but it's good enough. I don't need to actually do anything. Let's think we can measure precision. We can measure precision with some psychophysical instruments. This is some tools developed by Frank Hetzman's in my lab. In an effortful vision motor task, you have a force pad, you have to press the force, and it's a bit like Angry Birds. We wanted to call it the Angry Birds task, but we didn't want to get sued, so it's basically, you bring back the catapult and you project the Angry Bird, hit the target, and it goes flying across the screen. Well, we know it's very sort of deterministic in the mechanics of the task. We know from the force, we know where it will land, and you can see where it lands on most trials. But in other trials, there are catch trials, we need you to tell us where you think it would have landed under the same parameters as the model. And by looking at the performance error and people's expectations or belief about their performance error on the CATCH trials, we can do some nice psychophysics and get a measure of how precise, how confident they were in the outcome of each trial. Okay? So we get a measure of the precision of the action outcomes. And this is abnormal. Okay? We can measure this in older patients and Parkinson's disease and young adults, and it's abnormal in the diseases. But more importantly, the precision correlates with apathy. So this is some early data we had from Frank Hetzman's in both controls and Parkinson's patients. We can do the same with people with frontotemporal dementia and PSP, and you get the same strong relationship between the precision that we can measure psychophysically and the clinical measures of apathy. This graph's looking at the apathy evaluation scale. If you prefer Masood Hussein's AMI, you get the same result. It's not about how you're measuring apathy. Any of these clinical measures give you a similar result. It's the precision of the action outcomes. So now we can say, what's the biological basis of precision? That becomes what we're chasing now. What's the biological basis that gives you a precise or an imprecise belief in the outcome of your actions, from which you will then either act or not act? So this is work I'm going to present mostly from Rebecca Williams on the top left, but others in the group either developing on the psychophysics with Frank Hetzman's, the MEG, particularly with Tally Adams and Laura, and the Amir Jafarian, or indeed in the neurogenergic story we'll come to in a moment with some advances in imaging and clinical psychopharmacology. So let's think about beliefs. What are we acting? What is the goals that we want? Okay, let's think about that for a moment. I want you to think about, why do we behave in the way we do? Well, I want you to imagine it's your birthday. Okay? You know it's your birthday. It's a very enduring trait. Okay? It's the same every year. Okay? So it's quite an abstract concept, your birthday, and it's extended over time. When it's your birthday, let's say you're going to celebrate. You're going to organise a tea party. Okay? Tea party is much more confined, sort of spatiotemporally, and there's some, we call it task set. There's a series of rules and behaviours, sort of semi-complex patterns that put together a tea party. Okay? And if you're at the tea party, you might then want to pick up your tea or your cake and eat it. So you go from these enduring, temporally extended, highly abstract concepts around it's my birthday, through to more spatiotemporally localized task sets, okay, rules and complex behaviors, semi-complex behaviors, through to motor actions, movements. Okay, and these are hierarchical in their temporal duration and their complexity. This lower end here is around the kinematics. This is really where akinesia comes in, the kinematics of motor control. But that's not apathy. Apathy is more about the sort of upper end of this hierarchy. And this hierarchy is represented across the brain in spatially extended networks. I mean, as you move particularly forward to the frontal lobe, you start to see representations of these more complex, temporally extended episodes and rules for life, if you like, and long-term goals. It's my birthday, and I want some cake at a tea party, and now I'm going to lift up the cake to eat it. These are sort of hierarchy of behaviors. They're hierarchically arranged, and so we can start to use brain imaging to pick apart the deficits and think about what's driving the representations of action that will govern our behaviors, or the lack of behavior that we call apathy. Well, in the brain, each of these areas has actually relatively stereotypical arrangement of neurons. You have superficial and deep pyramidal neurons, spinal stellate cells, inhibitory neurons in cortical columns and laminae, if you remember back to your early physiology. In neurophysiology, so it's highly stereotyped. We're particularly interested in the gain function on the superficial pyramidal cells that are feeding forward and back information between brain regions. This gain function, I'm not sure, that pulse? I can't remember that. Yeah, we are. This gain function, it's a kind of tuning function. It's this gain that gives you the sensitivity to express the precision of that belief that you then feed back or you receive from higher levels. So as you move through the hierarchy, you need to be sensitive to the forward and backward message passing, particularly through the gain. So this is a sort of cartoon. Well, this comes on the back of some, I call it proper physiology, and looking at, both at microscopy and invasive electrodes, looking at the properties of different pyramidal cell populations and spinal stellate cells, connecting to each other locally within the cortex with AMPA and GABA and NMDA-based receptors. And this means that the electromagnetic flux you see at the postsynaptic potentials and traveling down the dendrons as cells are active and communicating, this will have its time constants determined by the properties of each cell type and the receptor types. and the membrane conductances and the time constants of each receptors that will be similar but slightly different from all of us. Okay? And this is estimable with a relatively, it looks a little bit complicated, but it's relatively simple equations in principle that basically says it is a deterministic model. You get your neurotransmitter goes across, it opens up a channel, there's ions flow across, you get a depolarization, and then a repolarization a few hundred milliseconds later, and then you get an axon potential. Okay? This is deterministic, and it's determinable. Okay? So we know that because the cortical columns are arranged very regularly, all point in the same direction, from down to the cortex. So they're summed electromagnetic fluxes, what sum up, and we can measure that on the outside, non-invasively, using MEG or EEG. That's the basis on which you get an EEG or MEG signal. Okay? So we've got a deterministic forward model from the neurophysiology of the human cortex. You can validate it in rats if you like, but I'm just going to talk about humans. We've got a deterministic forward model, and because it's deterministic, it's fully invertible. Okay? You can go backwards and forwards. Okay? So because we can go backwards, we can then measure MEG and work backwards to understand what in that person in the scanner, what is the basis of the generators of that person in that region of the cortex, what's generating that EEG or MEG in terms of the glutamatergic and GABAergic neurotransmission, and the AMPA and the NMDA circuits, and so on. And we can look at the connectivity. And MEG is a lovely environment for patients. You're sitting up, the lights are on, it's quiet, it's comfy, and patients find it very, very easy. It's much nicer than MRI to get the best out of a brain that's struggling. So we use a lot of MEG with our patients with Parkinson's disease, PSP, FTD, and other disorders, Alzheimer's. It's a very nice study environment. And what we can then do, we can then quantify the determinants of that neurophysiology. So we can get results. We use a method called dynamic causal modeling. I'm not going to, in this audience, go through the details of that, but basically this idea of inverting that biophysical model from the MEG back to the brain, forwards and backwards. And we can look at how those features, those cellular features, relate to psychophysical properties like precision, or indeed just behavior, like apathy. So in frontotemporal dementia and progressive supranuclear palsy, the loss of precision that we can measure psychophysically, the loss of precision that's the driver, psychological driver, if you like, or cognitive driver of apathy, that's directly related to the gain, the tuning function, okay, of those pyramidal cells. And it's impaired in the patients compared to controls. This is a summary graph just looking at the deficit in patients versus controls. It's most severe in prefrontal cortex, modestly affected in premotor cortex, and your motor cortex is normal, okay? Goes with the fact you're not akinetic, your kinematics are normal, okay? But the patients, their gain, superficial gain, and the connectivity, the degree to which prefrontal can speak to premotor and premotor can speak to motor, that connectivity correlates with the precision of our outcome priors that we've measured psychophysically. And that will then lead inevitably to a failure of goal-directed action in order to apathy. So we can then think about the way in which higher order goals around marking your birthday, arranging a party, bringing a guest over, baking a cake. These are things which, when you don't do, we call you apathetic. Okay, it's not that you can't move; you just don't move in interesting ways to do interesting things. It's because these higher order representations fail in their local neural instantiations and cannot communicate with lower order and eventually motor effector mechanisms, so you do not act. And it's the weak priors that make the actions just unnecessary. It's not that you don't want to. It's not that you don't know it's your birthday. It's not that you don't like presents or cake. It's just liking cake and liking presents isn't enough to make that behaviour is actually necessary. So you don't need to have a birthday. You kind of almost had your birthday without organising it. You're close enough. You've almost had your cake without eating it. Okay. The world as I see it is as if I've had the cake. I'm close enough. So how can we take this in the last few minutes? How can we take this sort of theory of apathy and the network neuroscience? How can we bring it towards novel therapies? So I'm going to move quite quickly now into the world of noradrenaline. And Stefan touched on noradrenaline this morning. Pretty much all our cerebral noradrenaline comes from a tiny region called the locus coeruleus. It's a tiny, thin little, barely even nucleus in the brainstem. It's like 50,000 neurons. It's nothing. Okay? Absolutely nothing. But it's devastated by these apathetic disorders. In PSP, you may lose up to 90%. Okay, of your noradrenergic capacity. Even in Parkinson's disease, you can have very severe, in fact, the earliest of the cerebral nuclei affected by Parkinson's disease and Alzheimer's is the locus coeruleus. It goes really, really early, okay, and it's profoundly affected. And we can measure it. You can actually see it at post-mortem. This little black dot here, this is just a plain photograph. It's a black dot. It's black dot because inside there are hundreds or tens of thousands of black cells. They literally appear black because they're full of neuromelanin, which is an iron-rich, proteinaceous, iron-rich compound. And because it's chock full of iron, it distorts the magnetic field. If it distorts the magnetic field, you can use an MRI scanner to image it. So it's beautiful images. This little dot here is exactly the same as what you see to the naked eye. Okay, so you can now measure it. If you measure it, you can see that it's impaired in living patients with Parkinson's disease, it's more severely impaired in patients with PSP, and indeed how apathetic you are on a classic AES, the Stark-Stein Apathy Evaluation Scale, correlates with how degenerate your locus coeruleus is. So the loss of locus coeruleus correlates with how apathetic you are. So you lose noradrenaline capacity, you're more apathetic. So that's just a correlation, but is this causally relevant? Well, we can ask the question, would making our noradrenergic system work harder help? Okay? And we can make the noradrenaline we can make work harder by giving a reuptake inhibitor. So everyone will be familiar with serotonin reuptake inhibitors to increase serotonin in anxiety and depression and other disorders. There are also drugs licensed for use that can increase noradrenaline. Venlafaxine is an example, which is a rather sort of dirty pharmacological profile. We use atomoxetine, it's more selective, noradrenergic reuptake inhibitor. You can also use direct agonists if you wish, but we work a lot with atomoxetine. Very well tolerated in elderly, very few side effects, and very, very few serious side effects, even more important. And I've shown you before that how apathetic you are depends on the precision of the prior. When we give atomoxetine, this is a double-blinded placebo-controlled crossover study, there is an effect of atomoxetine on the priors, but only in some people. Okay? Whether it benefited you as an individual depended on the state of your locus coeruleus, as we determine by imaging. Okay? So there's baseline dependency. If you are one of those patients who had a very degenerate locus coeruleus, you benefited behaviorally from the drug. If you were lucky enough to have a normal-ish locus coeruleus, there was no point in having the drug. You didn't benefit. In fact, it made you slightly worse. So you've got really strong baseline dependency. So the noradrenergic enhancement can restore this mechanism of apathy according to the state of your individual locus coeruleus. Actually, when we looked in further detail, this was most apparent in people who were behaviorally apathetic. But that's an apathy. We spoke a lot about how apathy and impulsivity come together. They're closely related. They're Burke and Hare rather than Jekyll and Hyde. They go together. A quick hop, skip, and a jump. There's a lot of work on using atomoxetine in Parkinson's disease and Parkinsonian disorders, and Stefan touched on some of this earlier, showing that we can improve response inhibition behaviorally, we can improve the neural responses in Parkinson's and related disorders. I'm going to show you just two studies to really kind of give you some handle on the extent of that effect. This is work from Zheng Yi. This is using the stop signal task that Hugh talked about first thing this morning. We're using a standard dose of atomoxetine versus placebo. We established at baseline that patients performing this task have abnormally low activity in that prefrontal cortex and the SMA, actually two areas that Hugh highlighted in his talk. If we then, and these are two areas consistently activated when you try and perform this task if you're a healthy control. Parkinson's patients, they're reduced in activity and they have low connectivity between them. If we give atomoxetine, let's just say they're low in activity. If we give atomoxetine, the activation in this area on average is increased compared to placebo. But there's a lot of variation, okay? And this, we looked here in terms of disease severity, there's a lot of variation. So the activity there for inhibition and the connectivity is reduced by PD. It can be restored by atomoxetine, but only in some patients, okay? Not in everybody. So you need to think about precision medicine and predictions. But just to reinforce the idea that noradrenaline controls the connectivity and activity in this prefrontal network for behavioral regulation. I'm going to take you to the work from CamCam, Cambridge, as a population-based study of healthy adults across the lifespan, using these same two areas with fMRI to understand their activity and connectivity. And we're going to ask, does the noradrenaline capacity in the locus coeruleus predict behavior? Well, the answer is yes. There's a very strong correlation, even in healthy controls as we get older, that your intrinsic noradrenaline capacity influences your intrinsic inhibitory control. But how does it do that? You can't just go from the locus coeruleus straight to behavior. That's not, it's not possible. It has to be mediated. Turns out it's mediated by the modulation of the effectiveness of this prefrontal control network. We're back to the pre-SMA and the frontal control network. We measure the locus coeruleus by fMRI. This is this tiny little streaky dot in the brainstem. We can measure that in everybody. And what we show is that, yes, there's a relationship between locus coeruleus and behavior, but that's explained by the way the locus coeruleus changes, even in healthy controls. There's prefrontal connectivity between prefrontal and pre-SMA, just as it had done in that patient and drug study with Parkinson's disease, the same connection. And it's that connection which governs the actual behavior. So you've got noradrenergic regulation of prefrontal circuits for behavior and those apathy markers. So, as I said, lots of work on this work in atomoxetine influencing inhibitory control. But actually, atomoxetine, there is some evidence going a while back looking at neuropsychiatric and non-motor symptoms. This is quite old literature, and they didn't, for reasons of what they were looking for at the time, particularly around depression, they didn't quite use the right outcome markers, but there were signals around neuropsychiatric benefits of atomoxetine. And other noradrenergic drugs have come to the fore for not just inhibitory control, but also apathy. That's one of my favourite studies, because it's a very large, well-conducted clinical trial, a series of clinical trials from this group taking it through phase 2 then phase 3, showing that methylphenidate, that works on both dopaminergic and noradrenergic systems, can improve apathy in patients. And then I was delighted to be part of a fantastic meta-analysis with Michael David in a very nice journal, GNP, showing in Alzheimer's disease, we did a meta-analysis of studies using noradrenergic drugs, a range of drugs. There's guanfacine, there's some methylphenidate, there's some atomoxetine, a whole range of drugs. So they've all got in common, at least they work on noradrenergic systems. We do see a net benefit, in fact, individually in most studies, and in aggregate, a benefit on apathy. So noradrenergic drugs may help apathy. And Parash Malhotra at Imperial is coming to the end of the NORAD trial using guanfacine to treat apathy and AD. We've been running a phase 2 study of atomoxetine in PSP with the last patient in this month. Trials, oh my goodness, trials, they're hard. Anyway, nearly done, nearly there, and we're very excited for later this year to get the readout. Anyone who's done trials, do respect them and be nice to them. They're horrible to do, but they're really important. But the magic about atomoxetine, these noradrenergic drugs, is that it not only may treat apathy, but, as I've highlighted in the previous work, it can treat impulsivity. So you're not driving people with this awful choice potentially between apathy or impulsivity. You're saying, no, we can treat both concurrently. The biology of both has much in common, and the treatment will be in common. You can treat your apathy and impulsivity jointly. So we're nearing the end of this NORAPS trial, thanks to Rob Durkin, who's been leading this with me in Cambridge, and really very optimistic. We know from the baseline data in these participants, 80 patients, that their impulsivity and behavioural challenging behaviours correlates with their individual baseline locus coeruleus at baseline. So going into the trial, we've reaffirmed in PSP that their noradrenergic capacity determines their behavioural performance going in. What we want now to do is, at the end of the trial, 6 months' time, we'll know if the drug helped behaviour. So last couple of minutes, just to sort of summarise where we've been. Well, I talked about apathy and impulsivity jointly, that they're Burke and Hare, not Jekyll and Hyde. They are positively correlated, whether you take a categorical or a correlative approach. And together, they're really bad for your survival outcome. I talked about a new model, getting away from this simple this reward cost-benefit analysis and just saying goal-directed actions become unnecessary if you don't represent the outcomes of your actions properly. And that those priors, prior precision, is affected by all these disorders that have apathy and impulsivity associated. Those priors relate to noradrenergic capacity and your clinical apathy. I've touched on trying to understand the biology, both from a systems neuroscience and network approach, but perhaps therapeutically, even more importantly, through the psychopharmacology, and with some very exciting, sort of promising developments in new treatments. Thank you for listening. Thanks, of course, to the fantastic team who've actually done the work. Thank you.
Thank you so much for that absolutely incredible talk. We have one speaker less in the following session, so we're able to shift the times a little and still have good time for questions. So, over there, please wait for roving mic, which is on its way now.
Thank you, James. I look after people with Huntington's disease, and your talk rang a few bells and made me think of a few experiments. What I see mainly in my patients is not an imprecision of prediction, it's just an absence of prediction. They seem to just fail to imagine anything that they might do in the first place. Somebody suggests it to them, they can reason around it, but it just doesn't seem to, the alternatives just don't seem to come into their head at all.
I'd agree, and that's the clinical impression you get when you put it into words, you have a conversation. But what I'd say is the reason it's not well articulated is the representation of an outcome is very imprecise, it's vague. It is precisely this. If you actually say, do you like it when your kids come? Do you like it if someone takes you to the seaside? They'll say, yeah, if you put it like that, yes, I do like it. They're not anhedonic, but they cannot project forward into what it would concretely look like to have a good outcome. I think you've put it into sort of natural words very well. And I think the problem, I focused on FTDs and Parkinson's, but the same will apply, the same basic model transfers across into HD.
Thank you. Over here.
Thanks very much. It's a pharmacological question.
I've lost
really.
you, sorry, can you wave? I can't see where you are.
Hello.
Oh, there you are, yes, thank you.
Hi. It's a pharmacological question. In the world of acquired brain injury, which is where I work, amantadine seems to be a drug that can be helpful in treating apathy following brain injury, and often, you know, where other drugs have failed or are contraindicated. You said earlier that the dopaminergic drugs don't tend to work now. Although it's not a direct dopamine agonist, my understanding is it sort of potentiates the effects of dopamine, although I think its mode of action is more complex than that. But it can be quite striking that patients who haven't responded to anything else do seem to respond to that. And I just wondered if you had any thoughts on how that fits with the pharmacology you were discussing.
Yeah, I do. I think amantadine is actually a very interesting drug. I use it quite a lot in clinic. I would draw the distinction between apathies. It's been used for almost 50 years for fatigue, where it came from in the early 70s. I think my MS colleagues still use it for fatigue. So apathy, fatigue, effort are sort of related problems, particularly after brain injury. I would think that if people have a sense of fatigue or heaviness or under-aroused, another problem in post-TBI, amantadine comes into its own. But it may be more to do with arousal and energization effects, not strictly speaking apathy. Clinically, I've become a little bit nervous of amantadine, particularly in older patients. It can induce hallucinations, can actually make you more impulsive. So unlike atomoxetine, which tends to treat apathy and impulsivity jointly, there is an awkward thing about amantadine. If you make someone aroused and alert and animated, they may actually be more likely to do high-risk behaviours. But yeah, so I think clinically it's part of the armamentarium, but I see it as not treating apathy as such, but perhaps arousal and fatigue.
Yeah, thanks very much.
Thank you. There's a question there.
What would I tell you?
I just wanted to ask your thoughts on apathy and movement.
Yeah.
So I understand the logic of dissociating proprioception from that, but at the same time, this idea of thinking about the correlation between apathy and movement. Presumably the correlation isn't one, but equally it would be difficult to believe that it was zero, and you'd think that there'd be some form of association between the two.
Yes. If I just come back to this figure, there is a relationship. That's partly because of particularly the degenerative diseases don't have very strict demarcated boundaries. So if you were to imagine think about Parkinson's disease, where the early emphasis is around motor control and motor representations, but the biology extends forward both in the subcortical structures and in the frontal lobe, extends forward to have softer effects coming to premotor and subtle effects prefrontally. PSP and frontotemporal dementia have the reverse gradient, but they are gradients. So you have in frontotemporal dementia, most prominent effects prefrontally, subtle effects at middle level, and weak or marginal effects in motor. So there are soft gradients. So I think really it's hard to think of a movement disorder that does not have a cognitive correlate. Actually, very hard to think of a cognitive disorder that does not have a motor correlate. If you choose to look, okay, and if you're trained well enough and you look. So 50% of people with frontotemporal dementia get clinically meaningful Parkinsonism, akinetic rigidity. It's not Parkinson's disease-like, it's certainly not Parkinson's disease proper, but it's Parkinsonism, it's about 50%. So it's really, really common. Even Alzheimer's disease, path-proven Alzheimer's disease, can cause bradykinesia and mild rigidity. Okay, see it in the brain bank with no other diagnosis. So you can get these cognitive motor disorders overlap because of the pathological distributions of the disease that are not well demarcated. So that's I think that's one of the simplest levels. Say, why is there a strong interaction? What we can say, if I can just an extra minute, is I talked about the loss of precision in these more abstract, sort of higher order areas. I'd refer you to the work of Mark Edwards, I think Mark might even be here, and James Kilner, showing that in terms of kinematic control, so the akinesia can also be directly related to a loss of precision at this motor level. So the relative precision of sensory versus motor signals. It's a very well developed model of what we call active influence of motor control acting at this, I might call it low level of the hierarchy. Okay. So, and that's well worked out physiologically as well and treatable. There's also interesting links to the world of functional neurological disorders, we'll hear more about over the next 2 days. Again, Mark Edwards, very influential brain paper, probably around 10 years ago, give or take, on looking at a model of particularly functional paralysis in terms of a disruption in the relative precision of the forward and backward message passing at these lower ends of a sort of behavioural hierarchy. Okay, so good evidence of that around other motor control deficits. When I think about apathy, I'm thinking about these high order complex goals, not the movement as such. Thank you.
Thank you. Thank you so much. Yeah, wonderful talk, fascinating
Thank you
questions. And we'll move on to our next speaker now. Another round of applause for James.